Hi, my name is Ashley Simmons, and this is my head-to-toe assessment video. So first, when you come in to see the patient, you introduce yourself. I'm Ashley Simmons. I'm the nurse practitioner today. How are you doing?
Good, how are you?
Doing good. You'll first do a general inspection of the patient. You can gather a lot of info from that to tell if they're hurting anywhere, how their general characteristics are, how their well-being is, and their mood and behavior. Then you're going to have the patient empty their bladder and get them into a gown so that it'll be easier access. Which in this case, I'm just going to have him wear this button-down shirt and then just some pants for comfort. Then you're going to get some general measurements, which is vital signs and height and weight. So vital signs include blood pressure, heart rate, respiratory rate, and pulse. Pulse, blood pressure, heart rate, pulse, blood pressure, temperature. So then you're also going to get their height and weight, which he's 6'3", and weight is 235. So then next, you're going to go on to the assessment. You're going to first inspect. As always, you always first inspect, looking at his head and his facial characteristics, seeing if there's any lesions of his skin, seeing if there's any lumps or bumps or any swelling of any type, which there is not. Then you're going to feel his head, his hair, seeing if you can feel any growths or any lesions, any abnormalities. You feel the occipital lobe, seeing if there's any bumps or growths there. You're also kind of looking at the symmetricalness of his eyes and ears, which they are good, the placement of them. So then you're going to feel the facial bones, kind of palpate and see if there's any swelling or any bumps, if it's painful anywhere. You're going to then check the temporal mandibular joints, if you can open and close. Okay. You're going to palpate the sinuses, the frontal and the maxillary, and you're checking for swelling and pain. Any pain?
No.
Okay, very good. So then you're going to have the patient do a couple silly things, but they're very good to check the cranial nerves. So you're going to have the patient puff his cheeks out. Okay, can you stick your tongue out? Can you smile? Frown? Can you close your eyes tight? And raise your eyebrows? Okay, can you crinkle your forehead? Okay, and then that is it. So all of those will kind of give you an idea of kind of looking for symmetry, making sure everything's working the way it should. From there on, you're going to move on to the eye exam. So first you inspect. You're looking at the eyes to see if there's any abnormalities, how the eyelashes are placed, and making sure that there's no redness, no swelling. I'm going to pull down on the bottom eyelids and looking at the sclera and the conjunctiva. The sclera should be bright and white, and there should be no yellowing or jaundice. Conjunctiva should be pink, or should be red, no inflammation. I'm going to palpate the lacrimal apparatus, seeing if there's any pain there. Okay. Then I'm going to do a couple of vision tests. So first one I'm going to turn on my little light. I'm going to check his pupils for, on this side, when I shine the light into this side, the other side should, this side should constrict, and the other side should as well. And same with this one. Direct and consensual should constrict, and the other should as well. Okay? And then I'm going to check as well, put my finger up, have him look at an object in the distance. And when he looks at that object, his eyes should dilate. And when he looks at my finger, they should constrict, which they do. So that's very good. That's accommodation. So they are accommodating. Next, I'm going to do the fundoscopic exam of his eyes. So with my otoscope, turn the light on, put it to your right eye when you're going to be looking at his right eye. You're going to put your non-dominant hand on his shoulder and then wait for the red reflex. When you get that, slowly move in so you can get a little closer. Keep your fingers out so that you don't bump into him to possibly hurt him. So you're looking on the inside, trying to see the fundus, the macula, which you can see when he looks at the light, looking at the optic nerves, and the optic disc. So when you move the light, the otoscope, you should move your whole head together so you don't lose that red light. And that's very good. So that is the eye exam. From there, we're going to move on to your nose. So you first kind of observe, inspect, looking at the septum, looking for any deviation, looking for any abnormalities, looking at the skin, seeing if there's any possible lesions or anything, which there is not. I'm going to check his nares and see how well they work separately. So I'm going to cover up one nair and have him take a deep breath in and out. And you're looking, it should be quiet, you're looking for, see if there's any flaring of the nares. Which there is not. So that's very good. Then I'm going to push up a little bit on the bridge of his nose. You can tilt your head back a little bit. And then carefully look in. Be careful not to put it in too far to abrade the nose. So you're looking at the mucosa, looking at the septum, and you're looking at the turbinates, making sure that there's no polyps, which there is not. Not there being pink. And it is. Okay. So then I'm going to move on to the ears. So you first go to inspection as well. You're kind of just inspecting, seeing if there's any bumps or lumps, the placement of the ears in comparison to the eyes. You're going to do the tug test before you do the internal test. So you're tugging on the auricle, kind of tugging, seeing if there's any pain on the other side, any pain. So then you're going to look inside the ear. On adults, you pull back, up and back. And you look in, you're looking at the tympanic membrane, looking at the canal. The tympanic membrane should be good and white, pearly, transparent. You should see the bony structures behind it. Look at the ear canal too and make sure that it's not red or inflamed. And the tympanic membrane should not be bulging because all of these could be signs of infection or inflammation. So you do the same on the other side. And it looks great. Then I'm going to perform a couple hearing tests. First one I'm going to do is the whisper test. This one I'm going to occlude the side of your ear and whisper a two-syllable word and see if you can repeat it from the other ear.
Apple.
Okay, very good. And then you're going to the other side and do the same.
Baseball.
Okay, very good. Next I'm going to do is with the tuning fork. You're going to strike the tuning fork, do the Rennie test. You place it at the mastoid bone. Let me know when you can't hear that. You can still hear it. So, and that's just testing air conduction versus bone conduction. Air conduction should be greater than bone conduction. Next, you're checking to see if there's any lateralization in the hearing. So you're going to strike your tuning fork again and do the Weber test. Place it up on the top of the forehead. Let me know which ear you hear that in.
Oh.
Okay, and then that is very good. You should hear it in more. So that completes the ear exam. Did the nose. Next, we're going to look into your mouth. We'll do your mouth exam. So first, of course, you look at the external characteristics, see if there's any cracking, any drooping, anything going on there, which there is not. I'm going to have you open your mouth, and I'm going to look at the buccal mucosa, looking at the pillars, looking at the, we're doing the otopharynx exam, so I'm looking at the posterior pharynx, looking at the uvula, making sure soft and hard palates look good, there's no lesions. Looking at his teeth, the placement of his teeth color. While you're here, you can kind of get a grasp of odor, see if there's anything going on there. You're also looking at his tongue, looking at the color of his tongue, looking at the sides of his tongue, if you could lift your tongue up, looking at the floor of the mouth, looking at the sides of the tongue underneath as well to make sure that there's no lesions, and everything looks great. Then I'm going to do the ah test and the gag reflex. Ah test, I'm going to have you open your mouth, stick your tongue up, say ah, and the uvula should raise up, and it does. And then the gag reflex, I'm not going to gag him, but what you would do is touch the soft palate, and it should cause a little bit of a gag reflex right above touch soft palate right above the tonsils. So that is that. We're going to move on to the neck. So first you inspect the neck, make sure that there's no goiter, there's no growth, swelling, which there's not. Then I'm going to palpate. You're palpating the carotids, feeling for a thrill, which there's not. You're going to palpate the thyroid, and you can swallow. You're feeling the lobes of the thyroid, if there's any abnormalities, if there's a growth on the one side versus the other. And then you're also palpating the trachea. It should be soft, should be movable, and it is. Then I'm going to listen to the carotids and the thyroid for any bruit. Okay, very good. Could you extend your neck a little bit, looking for a jugular vein distension, which there is not. Then I'm going to palpate the lymph nodes. So you start off on the head, and you're palpating the preauricular, the postauricular, the tonsillar, the submandibular, submental, the superior cervical, posterior cervical. You'll palpate the occipital. And then the deep is hard to feel, but if you can turn your head to a side, sometimes you can feel it on the side that he turns. Then you're going to palpate the the supraclavicular and the infraclavicular, and then the axillary. And all those are good. So then I'm going to move on to your upper extremities. So I'm looking at placement of the shoulders, the upper arms. You're kind of looking at the skin, seeing if there's any lesions, anything that could be alarming for skin cancer, looking for any swelling. You're going to go down to the hands and pay particular attention to the nail beds. You're looking for clubbing, or if there's any discoloration, which could be a sign of some issues. Then you look at the knuckles and kind of the structure, seeing if there's any abnormalities that could be signs of osteorheumatoid arthritis, which there is not. I'm going to palpate the radial pulse and the brachial. And then you would do the same on the other side. So then I'm going to move to your chest. So if you wouldn't mind removing your shirt. So I'm going to do the posterior, if you could turn just a little bit. Okay. So first you're kind of examining again, inspecting, seeing when he takes a deep breath in and out, make sure it's even. You're going to go about the 10th rib and kind of push in a little bit. And when he breathes, your fingers should move away from the spine evenly, and they do. You're going to palpate for any percuss and palpate for any loose air, crepitus, and then I'm going to do some tactile fremitus, and this is checking for any consolidation. So avoid the scapula, and I'm going to have you say 99.
99, 99, 99, 99, 99, 99, 99.
Okay. I'll do the same on the front. Thank you. Okay. I'm going to start a little high. Go.
99, 99, 99, 99, 99, 99, 99, 99.
Okay. So then I'll go back to your back. I'm going to do something, a test to look for a diaphragmatic excursion. So what you do is have the patient take a deep breath in and exhale, blow it all the way out, and percuss down until you hear dullness. And okay, you're good. Mark that line. And then you'll have the patient take a deep breath, hold it, percuss down from that line until you hear dullness. Now you do that on both sides, and that is the difference between the two is the diaphragmatic excursion. So it should be usually between, some people say 3 to 6 or 5 to 6. So his is good. Then I'm going to auscultate his lungs. And last, I'm going to percuss, since I already palpated and auscultated. I'm just percussing his lung fields. Should be resonant. Okay. Then we're going to move to the front, and I'm going to auscultate his lung fields in the front. So just take a couple deep breaths. Okay. And his lungs are clear. Next, we're going to move to the chest, the heart, and lungs. First, I'm looking to make sure that there's no pulsations. He's not using any accessory muscles to breathe. There's, you're going to kind of feel down medial, the fifth intercostal space for the apical impulse. And then you're going to listen for the heart sounds. So you're going to listen second intercostal space, aortic, pulmonic. Third is Erb's point. Tricuspid is fifth, and mitral. So that is the heart and the chest. So then I'm going to ask you to lay down, and I'm going to listen to I'm going to check out your belly. So you always first inspect. You're inspecting to make sure, see if you can see some peristalsis, checking up the abdominal muscles, seeing how they look. Then you're going to very first listen to the bowel sounds. Listen in all 4 quadrants. Okay. I'm going to also listen to the arteries, and so you listen to the aortic, renal, iliac, and then femoral, and you would listen to that on both sides. Then I'm going to percuss. Should be pretty tympanic. You're going to do some light palpation, see if there's any pain. Do you feel any growths or abnormal, any pain? Okay. Then you're going to do some deep palpation. So you're feeling any abnormal growths. Okay. Then you're going to try to feel the liver, trying to get the liver borders. So what you'll do is percuss down or percuss up until you hear some dullness. And then you percuss down, and that will give you an idea of the liver borders. To feel the liver, you can do the hooking method, or you can kind of push down and up. Take a deep breath. When the patient takes a deep breath in, it kind of brings the liver down a little bit and you'll feel it. Okay. Spleen is a little bit harder to feel. It is on the left side. So you'll kind of feel, you can palpate, percuss for it. The last intercostal space, kind of try to find that and just should hear it there. And then to get the idea of where the border is, I like to start a little low so I don't miss it. Percuss up, or palpate up. That should rub your fingers a little bit. It's not as easy to feel as the liver. So then I'm going to palpate the kidneys. Both sides. And then that's the abdominal exam. Then I'm going to do the musculoskeletal exam. And I'm going to kind of look over at his shape of his muscles, kind of feel, see if there's any abnormalities, if there's any growths. If the muscles seem like they're working great, check his reflexes and check the reflex of his knee with the flat end of the hammer. Okay. And then you're going to do the same for his Achilles. Okay. And then the upper extremities, you're going to do the same. If you put it up. So I'm going to check brachial radialis, and first you're going to check kind of the bicep area. So I'm going to have him turn his hand a little bit, rest in 9, and go right about here. You should feel it flex a little bit. Brachial radialis is down here. And then and that is the tricep that you'd be checking. So then that's the reflexes. You would do it on both sides. Next, you're going to check his extremities of his lower body, and we already kind of checked for Keller, and you can check for Keller temperature. See if you can see there. Keller temperature. You're checking to see if there's hair on the extremities, because if there's not, that would maybe be a sign of some vascular issues. You check the pulses, the dorsalis medial, check the posterior tibial, and then you check the popliteal. Okay? And then that is the next thing that you would do is check his muscle strength. So you can squeeze my hands. Then I'm going to pull up, pull down. I'm going to push down. Okay, very good. Then I'm going to have you stand up, and we're just going to look at the shape of your back. Yeah, let's go this way. Sorry. So the cervical should be concave. The lumbar should be concave as well. And the thoracic should be convex. So then you're going to have the patient lean down to touch his toes. And you can kind of see, make sure it's straight, there's no bulging, nothing going on there, and that's good. Very good. So that's the basic of the head-to-toe assessment. I'm going to kind of real quick go over the cranial nerves. The first cranial nerve is the olfactory, and that one you're going to check with the smell test. So you're going to have the patient close his eyes, get something that's a smell that's easy to decipher. What is that?
Leather.
Yep. The second one is the optic, and that one was the pupillary response pupillary response. The third one is the ocular motor, and you usually do with a Snellen test. The fourth and sixth, trochlear and abductans, you would do with the 6 cardinal fields of gaze, which I didn't do, so I'll do now. So you look in the center, out, up, down, back to center, up, down. Very good. The fifth is the trigeminal. So you'd have the patient clench his teeth, okay? Or you do the light touch, and usually use a cotton whisk, but I'm going to use my hand. Top, cheek, down. Can you feel all of that? If you couldn't feel it on one side, then you would go to the other side. The seventh is the facial, and that's when you do all the funny facial movements. Eighth is the acoustic, so that's when we did the whisper test. 9 is the glossopharyngeal, so we did the ah test. 10th is the vagus, so I could have you swallow or do the gag reflex. 11th is the spinal, so that's when I had you turn your head against my hand and turn. And again. And then the 12th is the hypoglossial, and that one you could say light, tight, dynamite.
Light, tight, dynamite.
And or stick out his tongue and make sure it's medial. And that's my head-to-toe assessment. My computer was about to die.